Welcome. Dr. DeBaun will be speaking on sickle cell disease, stroke risk, and novel preventative strategies.
All right, so thank you very much for inviting me. It's unusual for a pediatric hematologist oncologist to be at this meeting, but I welcome the opportunity to be here and the collaboration. I've actually, full disclosure, thought about revascularization trial when Deborah Hertz was at the NINDS about 20 years ago, and she says, no. So the case is the following: a 14-year-old child with sickle cell anemia receiving regular blood transfusion therapy for secondary stroke prevention, had a stroke 4 years after transfusion. What's the optimal therapy? This is our standard approach for managing this patient population: regular blood transfusion therapy, allogeneic stem cell transplant, and revascularization plus regular blood transfusion. I just want to hit hold for a second and say that about 1% of all children born with sickle cell disease live in high-income countries. So here is the option for those children. For children who live in Africa and India and areas in South America, none of these are options that are available for them. So how did we try to address this question? Formed a multidisciplinary team about 15 years ago, including neurologists, neuroradiologists, psychologists. We met annually for 5 years in St. Louis when I was at WashU. This was to come up with a common treatment approach, and it took us that long to agree on how we should manage these patients, despite everyone having very strong opinions. We shared our experiences between the hosts, between the sites, and we agreed on a standard care protocol. Critically important, we agreed on central adjudication for the MRI and MRA. Bob McKinstry was a neuroradiologist, and we had 2 other neuroradiologists at WashU who agreed to review the MRAs. And then we had minimal and central data collection. Here are the results of about 8 years worth of work. Our hypothesis was that despite regular blood transfusion therapy, recurrent infarcts are common in children receiving regular blood transfusions for secondary stroke prevention. And so 7 centers, 40 children. Our goal was to keep the hemoglobin S level less than 30%, which is considered standard care, and we reached that. Our mean pre-transfusion hemoglobin S concentration was less than 30%. We followed the patients for a mean of 5.5 years. Despite this, we had progressive cerebral infarcts, defined as overt strokes or silent cerebral infarcts, which we were able to determine because of the central adjudication and neurological assessment by a pediatric neurologist. I cannot underscore the importance of the fact that pediatric neurologists are better at evaluating children than pediatric hematologists. The hemoglobin S concentration at the time of the second stroke was, as you can see here, well less than 30%, indicating that this was basically palliative therapy for this population. 11 children had new silent cerebral infarcts. In our population, we would consider that, again, failure of our therapy, and this is one of the reasons why in this patient population you need surveillance MRIs, because you will miss more than 50% of the new lesions of the brain unless you evaluate them systematically with surveillance. There's a lot of data here, but because of time, I'll just want to review it. If you do not transfuse this patient population with transfusions, you can expect that the event rate will be 50% over 2 years. That's 29 events per 100 patient years. If you do provide transfusions, over a course of 10 years, we showed that 22% of those patients had a stroke despite optimal transfusions, with an event rate of 1.9 events per 100 patient years. And the highest rate of stroke recurrence is in the first 2 years after the initial stroke. This is very important when I talk to you about the revascularization procedure data, because you have to adjust for this higher risk within 2 years of the initial stroke. Despite that, you'll see that a recurrence occurs in 45% of the patients with the follow-up as I just described. And what I didn't show you, but we have the data, that 100% of those with progressive moya will have CNS lesions based on progressive vasculopathy. What about allogeneic stem cell transplant? This is emerging as a curative therapy, not only allogeneic stem cell transplant, but gene therapy and gene editing with CRISPR technology. There is only one of these trials, one funded by BMT CTN, which I'm one of the co-chairs, that will prospectively evaluate neurological outcome in children and adults with central adjudication of the MRI. All the other studies have not done this in a rigorous fashion. I just want to point out some of the work that was done at our site, which looked specifically at the haploidentical bone marrow transplant to test the hypothesis as to whether this transplant will dramatically improve cerebral hemodynamics to attenuate the risk but not eliminate the risk of infarct recurrence. There's one slide here. Here are 4 patients. It's more of a proof of principle. To this audience, I don't have to point out to you the last 3 columns, namely the change in hemoglobin, the change in OEF, and the change in cerebral blood flow, all going in the direction that you would expect when the baseline hemoglobin is in the double digits as opposed to typically 8, 9, which is often the case when we transfuse children to prevent strokes. But also of note is that because Lori Jordan, a neurologist, actually examined this patient, and we had central education of all the MRIs, despite this treatment, we still had a patient with a silent cerebral infarct, suggesting that it's either a conditioning regimen or peri-transplant conditions that may, in fact, still result in progressive brain injury. If we had not assessed this patient, we would have all patted ourselves on the back and said we've done a great job, and we have prevented any further neurological injury in this patient population. So what about revascularization plus regular blood transfusion therapy? So I'll give you a clear disclaimer, and that is for 3 years, Christine Fox, Bob McKinstry, Lori Jordan, Fenella Kirkham, and I and others reviewed the literature as carefully as one could, and we reviewed every revascularization procedure available, and we concluded with the methodologists from the Mayo Clinic that we could not pool the data because it was there were many challenges. One of the challenges, as this group already knows, is that there are multiple revascularization procedures, and so they are all not created equally. But despite that, what we were able to do is look specifically in 7 of the 14 studies, because these was almost exclusively from the neurosurgical literature. They all followed the patients uniformly for 30 days after the surgery. So we were able to identify within those 7 studies of the 14 the following. They were all retrospective, unable to pull the data, as I mentioned. There was no appropriate comparison group. There was no analysis suggesting for the high stroke rate within 2 years after the stroke. So when they did a before and after, they never adjusted for the fact that the after clearly had a lower stroke rate because of data that we had provided. There was no central adjudication process for determining neurological injury. Here's the pooled analysis where we had the data for 1 month post-surgery for the 7 studies. I'll draw your attention to the circle, and as you can see, the event rate is almost 200 times greater than transfusions, 193 CNS events per 100 patient years versus 2 events per 100 patient years for CNS events in this population. These data give me great pause as a hematologist to recommend performing revascularization procedures. So what would we suggest? I'll go to the last slide. This is what I was part of the writing committee, and the bottom line is I think I'm at a point where I would say probably not, but if you elect to, as a neurosurgeon or neurologist, to recommend this procedure, then I would say at least register it with clinicaltrials.gov, make it more than a single center, have prospective evaluation for the patients with central adjudication or the neurological examination by the neurologist and neuroradiologist to ascertain if we truly are doing benefit for this high-risk patient population. Thank you.